Hello, friends. Hello. Good evening. Good evening. Good evening, everyone. Hello. Okay. Just to cross check, am I audible? Are you able to see me? Are you able to hear me? Just a thumbs up would help us to confirm that you are able to uh, receive the audio and video feeds, and we can immediately start. All right. So what I'll do is I'll quickly just take a look at few of the images. See, Biochemistry has some important images which you should be knowing. And once you've looked at the images, then I'll look at some of the very important points which I expect are likely to land up in your exam. Okay. So I'll go from there. And I think one of the most likely and hottest questions in image-based questions is the Lesh-Nahan syndrome. I assume all of you will agree with this, the Lesh-Nahan syndrome. So you have to make note of the self-mutilation tendency in children. The only differential diagnosis for self-mutilation tendency will be the Lesh-Nahan syndrome, where you can see the bite marks or the nibbling of the fingers or the lips, the bite marks on the hands. These are some of the characteristic features for the Lesh-Nahan syndrome. Very good. And as most of you have already guessed, the absence there is absence of the enzyme HGPRTase. Please make very special note of this term which I've said. There is absence, not decrease. When there is decrease, that is a Lesh-Nahan variant. So the Lesh-Nahan syndrome is the absence of the enzyme HGPRTase, and the self-mutilation tendency is a part of the psychiatric component of the presentation. In addition to psychiatric component, you also have the neurological component and the biochemical component. One of the most important features here will be the hyperuricemia. So please don't forget the hyperuricemia presentation. And the neurological feature will be mental retardation, so poor performance in the school. And along with that, they can give the description of aggressive behavior, frequent quarreling and frequent fighting with the siblings. So aggressive behavior can be one important feature. Okay, so if the decrease is there, okay, so if you're asking if the decrease is there, we call it the Lesh-Nahan variant, and sometimes it is also known as the Kelly-Siegmiller syndrome. It is known as the Lesh-Nahan variant or the Kelly-Siegmiller syndrome. And in this case, the psychiatric and the neurological features will not be there. These will not be there. So what you get is only hyperuricemia. In Kelly-Siegmiller syndrome, the only thing you get is hyperuricemia. Neurological and psychiatric features are not there. So please remember, Lesh-Nahan syndrome, one of the most likely a question to land up in your exam, either in the form of English question or in the form of a proper clinical case. Okay. Then another important image which has been landing up frequently for the last 2 years, we have had this image or description multiple times, and that will be the phrynoderma. See, previously we've been having the white rod spot for the vitamin A deficiency. Please remember that, very good, that when there is keratinization of cornea, along with that there is keratinization of the skin also. So what you can see here, what you are seeing here, these are described as the keratotic changes. These are described as keratotic changes. So you are likely to get the phrynoderma. You're likely to get the phrynoderma. Typically, along with vitamin A deficiency, there will be other deficiencies. In addition, in the question itself, they can mention that the white rod spot is present. So it will indicate, further confirm that this is a vitamin A deficiency. So please look at this image. You should be able to identify this when we are talking about the keratotic changes in the phrynoderma. Okay. The associated white rod spot is here. You can see the white rod spot where you are likely to get this elevated shaggy patch. This elevated shaggy patch on the sclera is there. The elevated shaggy patch on the sclera is there. So this is the characteristic bite dot spot. So you are likely to get the bite dot spot. Very good, very good. All right. So that's one, phynoderma and the characteristic changes in vitamin A deficiency, and this very characteristic Casal collar, or sometimes described as the Casal necklace, characteristic of the pellagra. All of you know pellagra. Okay, so in pellagra, what you have to remember, the vitamin B3 or the niacin is deficient. The B3 or the niacin is deficient. And when we talk about pellagra, we mention the 3Ds. So here you have diarrhea. Along with that, you have the dementia. And about the dermatitis, you have to remember two things. About dermatitis, please remember two things. Number one, this dermatitis is photosensitive. And second, along with the photosensitive nature, you also get stomatitis. The stomatitis resembles what you see in the B2 deficiency in A. riboflavinosis. So Casal collar or necklace, the diarrhea, dementia, and dermatitis. Dermatitis is photosensitive in nature, and along with that, you're going to get stomatitis. When we say that the dermatitis is photosensitive, what it exactly means is only in the sun exposed areas, you will see the pigmentation. So it will be in the face, on the hands, and the part of the neck which is above the collar, so that is why collar shaped pigmentation is seen. Sometimes the pigmentation may not be as harsh as this. You can see, you can get the lightly pigmented image of the neck as well. So please be careful, don't always look for the highly pigmented lesions. You can also get the lightly pigmented lesions. Okay, so very careful about the Casal collar or Casal necklace. Has to be in the sun exposed areas. Okay, so we have these three important images which will be related to the urine. First one, as you can very well tell, this is the Benedict's test. The first one is the Benedict's test. Very important. Benedict's test is for reducing substances. Benedict test is for reducing substances. One of the very commonly presenting image in your exam. You should remember, you're performing this test in the urine. You also get the positive Benedict test with vitamin C, with uric acid, with amino acids. So these will act as false positive for the Benedict test, because normally we are performing the Benedict test for reducing sugar. Okay, so you can label the presence of these substances as causing the false positive result. Second is the heat coagulation test. Heat coagulation test, which is for the proteins. What you're doing here, you heat the upper half of the solution. If the protein is there, then the cloudy presentation will be there. More is the protein content, more is going to be the frothiness or the opacity. All right, and the third one that you are likely to get is the Rothera's test. The Rothera's test, as a lot of you have already written, the Rothera's test is the test for the ketone bodies. The first two tests that we have shown, the Benedict test and the heat coagulation test, both of them are giving you an idea of concentration. See, traces, moderate, large amount. Similarly, here when the frothiness is there, the opacity is there, we give the rating of +1, +2, +3, +4. So, like some of you already written, these are examples of semi-quantitative tests. Both of them are example of semi-quantitative tests, both heat coagulation and the Rothera's test. Talking about the ketone bodies, you have to remember the important ketone bodies and the points about ketone bodies. The first one to be produced is acetoacetate. Acetoacetate converted non-enzymatically into the acetone. The acetone is the one which is responsible for the fruity odor. of urine and breath. It is responsible for fruity odor of urine and breath. The acetostate also gets converted enzymatically and that too reversibly in the beta hydroxybutyrate. About beta hydroxybutyrate, what you have to remember that the beta hydroxybutyrate is a pseudo ketone, means it doesn't have the keto group, and therefore when you test it via the Rothras test, the result will be negative. So please remember, among the three ketone bodies, the beta hydroxybutyrate doesn't give the positive Rothras test. It is called as the pseudo ketone. It is called as the pseudo ketone. So this is about the Rothras test. The Rothras test is also known as the modified nitroprusside test. It is also known as the modified nitroprusside test. So if you see the term modified nitroprusside test or the nitroprusside test, you should remember that it is the alternate name for the Rothras test for ketone bodies. Okay. So we talked about these, and the last one among the important standalone images, this is the oil drop cataract. As you can see very clearly, cataract, oil drop cataract. Okay, so you can see here presence of drop like appearance in the eye. You can, when you're looking at the eye in the lens, it is showing the drop like appearance. Wonderful. As all of you know, this is the presentation of the classical galactosemia. So the enzyme which is deficient here, is the galactose 1 phosphate uridyl transferase. So sometimes you can see the name as gal 1 put. It can look like Galliput. When they write it, it can look like Galliput. So that is one way in which they can write the name, or they can write it as GALT, galactose transferase, or they can write it as uridyl transferase. So please be very careful about these names. Galactose 1 phosphate uridyl transferase, the galactose transferase, or the uridyl transferase. Okay, so please remember about these points. And about the classical galactosemia, the second very important thing you have to remember is the age of presentation is first week of life with neurological signs and symptoms. Sometimes in the question they might not mention the oil drop cataract, and in this case you will have to distinguish this similar clinical presentation which occurs at more than 6 months of life in case of what is known as the hereditary fructose intolerance. Similar clinical presentation, and only the age of presentation will be different. In fact, they even have the similar urinary findings. And what is the similarity in urinary finding? You will find that they have the positive Benedict's test and the negative glucose oxidase test. Okay, all right. So please remember that in classic galactosemia you cannot give milk, and you have to give them the galactose free diet or the lactose free diet, because lactose is also going to get metabolized into the galactose and cause the problem. So this at 6 months, what is happening in HFI when you're doing the weaning, the fructose is coming to that through the fruits. So till the breastfeeding is there, you will have the glucose and galactose coming from lactose but no fructose. When you do the weaning, that is when the fructose will come into the picture. So this first week of life for galactosemia and more than 6 months of life for HFI, for hereditary fructose intolerance, it has to be more than the 6 months of life. All right. So at this point, okay, one more. Different ways in which the image for the crumpled or wrinkled tissue paper appearance. Almost every year we have this paper. Different images will be there. Different images will be there. So crumpled or wrinkled tissue paper appearance. Wonderful. All right, all right. So I'm so happy to see that you're confident about what you're looking at. So this is the Gaucher cell. Gaucher cell. The only important thing you have to remember, besides the description that you just mentioned, that there is crumpled or wrinkled tissue for appearance, that we also have something known as the pseudo Gaucher cell, and this pseudo Gaucher cell is seen in the chronic myelogenous leukemia. Therefore, Gaucher cell is not diagnostic. It is not diagnostic for the Gaucher disease. So please remember that Gaucher cell is characteristic. It is seen very frequently in the Gaucher disease, but we can't call it diagnostic because we have a similarly presenting cell called the pseudo Gaucher cell, which is seen in chronic myelogenous leukemia. About the Gaucher disease, as you rightly said, the deficient enzyme is the beta glucocerebrosidase, and the Gaucher disease is the most common. This is the most common lysosomal storage disorder, and it is also the first condition for which enzyme replacement therapy was made available. The first condition for which enzyme replacement therapy was made available. So remember these points about the Gaucher's. Typical presentation is with the hepatosplenomegaly. Sometimes there can be the bone pain, or also known as the bone crisis. So these 2 points to remember about clinical presentation. Either it can present with abdominal pain, which will be due to hepatosplenomegaly, or there can be bone pain described as the bone crisis. Okay, enzyme replacement therapy is available for treatment of the Gaucher disease. I'll start from the beginning now. Okay. One other very important question, which I think is likely to land up in your exam, and it has been coming frequently, is the treatment of urea cycle disorder based on the biochemical molecules. Now, here we have two molecules. I'm sure all of you know. Okay, great. So, someone has written the name of the enzyme, aldurozyme. The first one to be launched for Gaucher's was the cerezyme, but now we have multiple other variants which are available. That is correct. Okay, so treatment of urea cycle disorder, there are two important biochemical molecules which can be given in all types of urea cycle disorder. You know there are 8 types of urea cycle disorders. So the two biochemical molecules which can be given in all the condition. The first one being the phenyl butyrate, and the second one being the sodium benzoate. Okay, for phenyl butyrate, you have to remember that phenyl butyrate is actually a prodrug. It is not the active molecule. It first gets converted into the phenyl acetate, which then combines with glutamine. The end result is the phenyl acetyl glutamine, which is readily water soluble and therefore excreted in the urine. Water soluble, and therefore it is excreted in the urine. Okay, first is phenyl butyrate, which is prodrug, gets converted to phenyl acetate and then combines with glutamine and gets excreted in the urine. The second one is sodium benzoate, which combines with glycine to form the hippuric acid, and again the hippuric acid is also water soluble and therefore it is lost in the urine. Wonderful. So in this case, what happens? Body has to compensate for the loss of these amino acids. It has to synthesize these amino acids. To synthesize these amino acids, it will use up the ammonia. It will use up the ammonia, and therefore ammonia levels in the body will decrease. The two drugs are non-specific. They can be used in any type of urea cycle disorders. All the 8 subtypes of urea cycle disorders, in each of them, this can be used because it is targeting the ammonia level. It is directly targeting the ammonia level, and therefore it is useful in all the different types of urea cycle disorder. Second is the Menkes disease, which I think is likely to land up. A lot of students will commonly confuse it when we talk about the genes in terms of the Wilsons. So remember ATP7A in Menkes, ATP7B. ATP7B will be for Wilson's. Now, in addition to knowing the gene defect, what you have to know, due to the deficiency of ATP7A, there is decreased copper in extracellular matrix. Decreased copper in extracellular matrix, and this copper is actually required by the enzyme lysyl oxidase. this copper is required by the enzyme lysyl oxidase. So there are three questions here. Number one, when you're talking about Menkes disease, which gene is defective? That's question number one. Number two, what is the effect of gene defect? There is decrease of copper in the extracellular matrix. And number three, which enzyme is getting affected? So when I ask you which enzyme is getting affected, there the answer is the lysyl oxidase. All of them are required, are involved in the cross-linking in collagen synthesis. Please remember, cross-linking in collagen synthesis. For Menkes, the two important features to keep in mind is poor growth, that is growth retardation will be there, and along with that there is what is known as kinky hair. Kinky hair is the important thing. Okay, so no, 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 please not. It is not prolyl oxidase. It is the lysyl oxidase. Lysine is getting oxidized. Asthacane. It is the lysyl oxidase and not the prolyl oxidase. Okay, please remember, enzyme is lysyl oxidase. Okay. Wonderful, wonderful, great. Now, I've just given for the Wilson's disease, as all of you are able to identify, this is the Kaiser flesh ring. You are likely to get this image also when we are talking about the Wilson's. In Wilson's, you have to remember the diagnostic test is liver biopsy, where you have to show accumulation of copper in the hepatocyte matrix. Okay, so please make sure that you're able to identify this image, link it with Wilson's, where defective gene is ATP7B, and confirmatory test is the liver biopsy. Confirmatory test is the liver biopsy. Wonderful. Now, very frequently we are getting this question that what happens in a patient of diabetes mellitus, and typically they are asking about the effect on lipoprotein lipase and the hormone sensitive lipase. LPL stands for lipoprotein lipase and hormone sensitive lipase. The first thing what we have to understand is, as soon as you mention diabetes mellitus, whether it is type 1 or it is type 2, there is a functional deficiency of insulin. In type 1, what is happening? Insulin is not being produced. In type 2, what is happening? No, prolyl hydroxylase is not the correct answer. It will be the lysyl oxidase. Dr. Diwali, it will be lysyl oxidase. Please don't worry. The answer will be lysyl oxidase. Lysine gets oxidized and combines with other lysine residues. Okay. Okay, so please keep in mind, when we talk about diabetes mellitus, first thing you have to understand whether it is type 1 or type 2, there will be functional insulin deficiency. In type 1, production is not there. In type 2, all the production is more, but insulin resistance is there. So functionally, insulin is not available. So that is point 1 you have to keep in mind for the diabetes mellitus. Now, about insulin, what you have to remember, insulin normally activates the lipoprotein lipase and it inhibits the hormone sensitive lipase. The lipoprotein lipase is acting on the triacylglycerol of lipoproteins. So in this way, the tissues are getting the triacylglycerol. The hormone sensitive lipase is acting on triacylglycerol of the tissues. So what is happening here? This free fatty acid is going in the blood, whereas in this case the free fatty acid is going in the tissues. Okay, so please remember very carefully, when insulin is present, when insulin is present, it is going to activate lipoprotein lipase, and when insulin is present, it is going to inhibit the hormone sensitive lipase. When lipoprotein lipase is active, it will break the triacylglycerol of lipoprotein and provide free fatty acid to the tissues. When hormone sensitive lipase is active, it will break the triacylglycerol in the tissues and provide free fatty acid in the blood. So they are having opposite action. They are having just the opposite action. Now, when I say that we are talking about diabetes mellitus, in this scenario, insulin level will fall and everything will become opposite. What was getting activated will become inactivated. What was getting inhibited will become active. Okay, so please remember, when we say diabetes mellitus, there will be decreased action of lipoprotein lipase and there will be increased action of HSL. Okay, please remember this point. When there is decreased action of lipoprotein lipase, there will be decreased stores of EAG. there will be decreased stores of TAG. When there is increased action of HSL, there will be increased free fatty acid in blood. There will be increased free fatty acid in blood. All right, that's perfectly fine. Great, great. Thank you. No, cave ring is not seen in monkeys. I showed that for Wilson's when we wrote ATP7B. Below that, I had given that image. Cave ring is not for monkeys. Cave ring is for Wilson's disease. All right. Coming to the very important electron transport chain. Coming to the electron transport chain. Now, most commonly the question which is asked is for inhibition of the cytochrome C oxidase, also known as complex 4. Please note, nowadays in the question they are not writing the number of the complex, rather they are writing the name of the complex. So you have to remember that complex 4 is also known as cytochrome C oxidase, right? Now, for the complex 4, the four names which you have to remember: carbon monoxide, cyanide, azide, hydrogen sulfide. These four names should be on the tip of your tongue. These four names you cannot afford to forget. For carbon monoxide, you have to remember, whenever you are burning fuel in closed space, for example in a very small room or in a vehicle, you have all the windows up and you're burning an angiety or something like that, that is where the carbon monoxide will build up. Hydrogen sulfide will build up in sewer lines. So history can indicate workers going to clear the blockage in the sewer lines and they become unconscious or they die. So that will be the buildup of hydrogen sulfide. Hydrogen sulfide will build up in the sewer lines. Please remember that. In addition to that, for the last 2 years, we have been seeing the question focusing on rotenone. This question is becoming important. First time when this question was asked, they talked about the use as pesticide. But more importantly, why we are asking this question is because nowadays in the shampoos of the pets, we are using the rotenone. Rotenone is present in the pet shampoo, from where it can cause poisoning in the children. So it is clinically very relevant. If the children ingest the pet shampoo while bathing the pets, they are likely to get poisoned. So this is very important. Rotenone you must know about rotenone. It is inhibitor of complex 1, and the name of complex 1 is NADH-Q oxidoreductase. Please remember the name, because in the question they might not give the number, they can give the name. This is NADH-Q oxidoreductase. The other name for Q is ubiquinone. So we have seen the question where in the option they have written NADH ubiquinone oxidoreductase, and a lot of students got confused. So please remember, Q alternate name is ubiquinone. So the question can mention NADH ubiquinone oxidoreductase, indicating complex 1. The other important inhibitor of complex 1, the amobarbital, secobarbital, or most relevant for you is the phenobarbital. These are additional inhibitors of complex 1. These are additional inhibitors of complex 1. Okay. Now, with the term of pesticide, you have to remember there is another pesticide, that is antimycin A. So don't confuse the rotenone with the antimycin A, which is inhibitor of the complex 3. Okay, so please remember, rotenone, when it is there in the question, sometimes they can provide the details that it is a tasteless, odorless substance. Tasteless, odorless substance becomes important, because when you are using it for bathing the pets, if it is having some odor or some taste, then the pets will not allow you to use it. They will become very restless. Okay, so that's about the cytochrome C oxidase, most important question. One last part here which I would want to mention is the F0 F1 particle is also known as ATP synthase, and sometimes this is also known as complex 5 of electron transport chain. And in this context, please remember, inhibitor of F0 is oligomycin. This question has been asked previously, and when it comes again, you should be able to answer. All right. Okay, so somebody is mentioning a tractyloside Anyone knows a tractyloside? Have you heard about a tractyloside? Anyone? A tractyloside? Very good. Who's written? SKSQ9OM. This is acting on ATP ADP translocase. Acting on ATP ADP translocase. Please note, a tractyloside will act on the ATP ADP translocase. This enzyme brings out the ATP from matrix. It will pull out the ATP from matrix and replace it with another ADP, which can be converted to ATP. So ATP ADP translocase is bringing out the ATP from the matrix after the synthesis, which is inhibited by a tractyloside. Yeah, antimycin. Please remember, antimycin is not tasteless, not odorless, and it is acting on complex 3. Okay, the Q cytochrome C oxidoreductase. It is acting on complex 3. Right. So that was 4. We move on. One of the very common question talking about mutation in the sickle cell anemia. Why sickle cell anemia? This is the most common abnormal variant of hemoglobin, most common abnormal variant, and that is why frequently you'll get the question on the mutation in sickle cell anemia. What you have to remember, in sickle cell anemia, the change is happening in beta chain. In each of the chains we have 8 helices, so the change is limited to a helix at position 6. And what is the change? Glutamic acid is converted to valine. Glutamic acid is converted to valine. This is a point mutation. This is a point mutation. This is a type of missense mutation. This is a type of missense mutation which is partially acceptable. Partially acceptable missense mutation. Okay, so please remember, it is a partially acceptable missense mutation in the exam, so that you don't confuse what came, what went away. Please remember this. The G is gone. Glutamate or glutamic acid is gone when we're talking about the HBS. Okay. Another very commonly repeated question that we're getting is how the vitamin B12 deficiency is going to happen. So sometimes they can give the clinical case like this. Patient had gastrectomy and now presents with loss of proprioception and tingling sensation with numbness. Which deficiency? So remember, the vitamin B12 deficiency can occur due to problem in 3 areas. Number 1, if there is any problem in the oral mucosa. Oral mucosa, you can have dry mouth syndrome, keratoconjunctivitis sicca. In the mouth, there is production of the cobalamin, which is responsible for protecting the B12 from the gastric acid. Similarly, when there is atrophic gastritis or you have done gastrectomy due to gastric cancer, what is happening here? The intrinsic factor is being produced from the stomach. This intrinsic factor is required for absorption of the vitamin B12 at ileum. And last, if there is ileal resection, then absorption cannot take place. So remember, any problem at any of these 3 places, then B12 absorption will not take place. In the mouth, you are getting the cobalamin. In the stomach, you are getting the intrinsic factor, and in the ileum, which is responsible for absorption. All 3 sides must be intact and working normally so that the B12 absorption can take place. Very good. Hyperpigmentation, pigmented knuckles can be there. And the main feature of B12 deficiency is what you describe as the pernicious anemia. When we say pernicious anemia, we have 2 components in picture. First component is the megaloblastic anemia. Megaloblastic anemia is due to the folate trap. And second is the SCD or SACD, subacute combined degeneration of the cord. This is the damage, neurological damage of the vertebral of the spinal cord, vertebral spinal cord. So subacute combined degeneration of the cord. This is the irreversible neurological damage which is happening in the B12 deficiency. In fact, if you have B12 deficiency and you supplement with the B9, the neurological defects can get aggravated. So please remember, when B12 deficiency is there, you cannot give the B9 alone. You have to give B9 plus B12. Okay, you also get asked about the distinction between B9 and B12 deficiency. This is very common. So what you have to remember, that we have megaloblastic anemia. I just mentioned megaloblastic anemia. Megaloblastic anemia will be seen in B9 and B12 deficiency both. In addition to that, what you will get is homocystinuria. Homocystinuria will be seen in both B9 and B12 deficiency. In addition to this, you are likely to get methyl malonic aciduria. Methyl malonic aciduria is not seen in B9 deficiency, but it is seen in B12 deficiency. And last, what you're going to get is the subacute combined degeneration of the cord, which will not be seen in B9 deficiency, but it will be seen in B12 deficiency. So with the help of these four features, you are readily able to distinguish between the B9 and the B12 deficiency. Two important common features and two important differences. So methyl malonic aciduria only in B12 deficiency, and the neurological deficit only in the B12 deficiency. Then we are also getting the questions on the vacutainers. Very commonly you're getting the questions on vacutainers. 2-3 out of the way questions on vacutainers which are there. One is for HbA1c. Okay, so as of now we are using EDTA. However, if in the question they are mentioning black vial used for, so black vial was previously used for the estimation of HbA1c. So you have to watch out for the presence of black vial in the option. Previously the black vial was used for HbA1c, which was specific for HbA1c, but now there has been upgradation of the equipment, and with the new equipment we are using the lavender top vial having the EDTA. So most of the laboratories have now shifted to newer equipment where you're using the lavender top vial for the estimation of HbA1c. Please also note that this lavender top vial is also used for the estimation of ESR. Oh, I'm so sorry. Black vial was for ESR. I'm so sorry. Black vial for ESR, HbA1c for lavender top, and now we are not using the black vial for ESR. Now we have shifted from black vial to the lavender top vial. No. Only for HbA1c, lavender top vial, ESR, lavender top vial. These you have to remember, which are extra. Otherwise, the routine vials that you remember, that is more than enough. One extra test you have to remember is for the ethanol in blood. How do you estimate ethanol in blood? Which vial you are going to collect the sample in? For this, you have to remember the gray vial. These are the only three extra you have to remember. Okay, what is to be done for HbA1c, what is to be done for ESR, and what is to be done for ethanol estimation. These are the three extra tests you have to remember. For ethanol you use the gray vial. For the ESR, previously we had black vial, but now we are doing the ESR also in EDTA vial, and HbA1c we are using the EDTA vial. So these are the three extra tests you have to remember. And for electrolytes you have to remember, it is done in serum. Serum will be obtained in the golden or the red top vial. Golden or the red top vial. Ethanol in gray. Ethanol in gray vial. Ethanol in gray vial. I am sure all of you know about the sequence of these vials. The first is for the blood culture, second is for the coagulation profile, the third and fourth, the red top and the gold top will give you the serum. We can do the biochemistry and the immunological parameters. The green top vials will give you the plasma. So some biochemical parameters need to be done in plasma, which you can collect in the green top vial. The lavender top vial and pink top vial are the same. They are having the EDTA for complete blood count or hematology, or for the you can say blood grouping. For blood grouping also you can use in the lavender top or in the pink top vial. They are exactly the same. The pink top vial only has a difference in the labeling. And the gray top vial for plasma glucose, it has sodium fluoride plus potassium oxalate or the EDTA. Please note, sodium fluoride plus strong anticoagulant is required. Very good, Saurav Nagar. Please remember, yes, you're right. When we are taking the sample for ABG analysis, classically, all of you remember that we take it in heparinized syringe, but now it is not required to take it in heparinized syringe because you already have the vacutainer, which is vacuum sealed, having the heparin. So this green vial is having the heparin inside. Heparin is already there. Okay, so you can take the sample in the green top vial for the ABG analysis. You can take it in ABG analysis. Till now they've not asked, but okay, you raised it, so I'm telling that you can take it in the green top vial. You don't need to use the heparinized syringe any longer. This is having a better vacuum seal than you can create by bending the needle. Okay, so please note, this is a better place where you can collect the sample for ABG analysis. Okay, again we are getting the question on the high anion gap metabolic acidosis very repeatedly. So I would expect you to remember this mud piles. Please remember this mud piles as the mnemonic for the high anion gap metabolic acidosis. Okay, electrolytes in serum. Serum is in red top or the gold top pile. RBS is in gray vial. RBS, I told you in gray vial, sodium fluoride inhibits glycolysis enzyme number 9, that is enolase. Okay, culture is always first. Culture is always first. We saw this. The first vial is always for culture. The first vial always for culture. If you require culture, it must be done right in the beginning. If you require culture, it must always be the first vial. Okay, what is the question at the end? Green was given, sir, so it's not at all green. No, see, the when you're looking ethylene glycol, we have not had question on ethylene glycol. For electrolytes, we had the question on HbA1c, we had the question on ESR. We have not yet had the question on ethylene glycol. We have had the question on ethanol. For ethanol, I told you it is going to be the gray vial. Black vial was used previously for ESR, no longer used. Now we are using the lavender top vial for ESR as well. Previously we are using the black top vial for ESR. So if in the question they ask black top vial is used for, then you can mark ESR. But as of now we are using the lavender top vial. We are not using the black vial. Electrolytes is in serum. You get the serum in the red top or the gold top vial. Okay. Electrolytes you measure in the serum. Serum is obtained from the red top or the gold top vial. Please forget black. We don't use black now. Black is outdated. We are not using for more than 5 years now in the country. Black is outdated. Please forget the black. Black pile, please forget. We don't use it now. Only thing you have to remember that if they ask black, you say that yes, sir. That's all. But now we're not using the black pile. So I'll leave it that we are not using black pile any longer in the country. So I'll not go there. Okay. Okay, so about ABGN lights, what you have to remember, the ABG analyzer will give you the electrolytes as well. Okay, so if you're sending the electrolytes separately, then it is preferably done in the serum. But if you're sending for ABG analysis, for arterial blood gas analysis, that equipment does the electrolytes as well from the plasma. That is doing the electrolytes from the plasma. But however, for the routine electrolytes, we are using the serum. Okay. Alright. The ratio will be 1:9. See what happens is in the vial it is already marked till what mark you have to take the blood sample. You don't have to decide what is the ratio. It is already marked till where you have to collect the blood. So ratio is 1:9, but you don't have to do that calculation. We are using the vacuum Vacuum is already having the label. Okay, let's come back to this high anion gap metabolic acidosis. Commonly in the question, it may be written as HAGMA, high anion gap metabolic acidosis. And remember the mud piles: M for methanol, U for uremia, D for diabetic ketoacidosis, P for paracetamol. And here you also have the paraldehyde, fenformin, polyethylene glycol. I for inborn error of metabolism. Please note, very important, inborn error of metabolism. And L for lactic acidosis, E for ethanol, again ethylene glycol, S for salicylates and aspartate. For D, remember any type of ketoacidosis. We write it for diabetic ketoacidosis, but any type of ketoacidosis which is there, for that you will have the diabetic ketoacidosis. Last point, in diabetic ketoacidosis questions you will not get the value of PCO2 and bicarbonate. You'll only get clinical scenario. You'll get the pH value. You have to identify that we are dealing with the high anion gap metabolic acidosis. In these questions they will give the clinical scenario, they'll give the pH, and that's it. So you have to identify that it is a type of metabolic acidosis. Okay, moving on to the very important question, and that is the B1 deficiency. B1 deficiency, causes two things: beriberi and the Wernicke's encephalopathy. Wernicke's encephalopathy is very commonly asked, so you should remember this. Wernicke's encephalopathy presents with what is known as GOA. Global confusion, ophthalmoplegia, and ataxia. All of you know that. Global confusion, ophthalmoplegia, and ataxia. Now, when there is Korsakoff psychosis, these two, amnesia and confabulation, will be feature of the Korsakoff psychosis in addition to the features of encephalopathy. Okay. In addition to features of synthropathy, when you have the amnesia and confabulation, and that is the Korsakoff psychosis. So please remember that point. Korsakoff psychosis will have features of Wernicke's plus amnesia and confabulation. For Wernicke's and Korsakoff, the treatment is IV thiamine. And if they have the hypoglycemia, then you give the 25% dextrose infusion as well. Okay, so global confusion, ophthalmoplegia, and ataxia. Along with that, you can have amnesia and the confabulation. Okay, moving on, we have the congenital lactic acidosis. Very, very common question. Lactosis can happen due to a lot of causes, but congenital lactic acidosis is commonly associated with pyruvate dehydrogenase deficiency, genetic deficiency of the pyruvate dehydrogenase. Thymine has to be given first. Yes, thymine has to be given first. Thymine has to be given first, and then you have to give 25% dextrose only when the hypoglycemia is there. Otherwise you don't need to give it. Okay. So talking about lactic acidosis, talking about lactic acidosis, it can be due to problem in the PDH complex. It is due to problem in the PDH complex, and it can be due to the B1 deficiency in chronic alcoholics. It can be due to inhibition of lipoic acid, due to mercuric and arsenite ions, okay. But lastly, it can also be due to the deficiency of pyruvate dehydrogenase. Moving on, very common question about the inhibition of enzymes, where we talk about the Line-Weaver Burke plot. So you should be able to identify the competitive inhibition common point on the y-axis, and non-competitive inhibition where the common point is on the x-axis. If you remember these 2 points, in competitive inhibition common point on y-axis, in non-competitive inhibition common point on the x-axis. If you remember these two, then your work is done. Okay. Yes, that also works. Competitive is a cross, non-competitive is an angle, so that equally works. Now we are repeatedly getting question on the familial hypercholesterolemia and the familial hyperchylomicronemia. Okay, so type 1, where lipoprotein lipase deficiency is there, you get elevated chylomicron, triglycerol levels are elevated. Common presentation can be pancreatitis, and in these patients what you can see is the cutaneous or the subcutaneous xanthomas. Whereas in case of the type 2A, the familial hypercholesterolemia, where LDL is elevated and cholesterol is elevated, there will be history of coronary artery disease, and you will get the tendinous xanthomas, So please remember tendinous xanthomas. No give synergy, no graph, no. Okay, so tendinous xanthoma and cholesterol elevation and coronary artery disease, whereas the subcutaneous xanthoma and pancreatitis when the triglycerol level is elevated. The other types are generally not asked, so will not go over there. The additional point only you can remember is type 3, where remnants are elevated. Just remember this point: in type 3, chylomicron remnant and VLDL remnant are elevated. Question on amino acid derivatives. 3-4 names I want to highlight. Number 1, that glucose from amino acids. Number 2, creatine requires 3 amino acid: arginine, glycine, and methionine. Required for synthesis of creatine, not creatinine. For creatine synthesis, you require arginine, glycine, and methionine. Third, for synthesis of nitric oxide, you require arginine. Very, very frequently repeated question for nitric oxide. Arginine is required. Enzyme is nitric oxide synthase. Then How do you get histamine? Histamine is produced by decarboxylation of histidine. Produced by decarboxylation of histidine, and the GABA is produced from glutamate again by decarboxylation. GABA is produced from glutamate again by decarboxylation. Three more names. Tyrosine is giving you the catecholamines, thyroxine hormone, and melanin. Tryptophan is giving you the serotonin, melatonin, and niacin. And methionine is required for production of SAM. Please remember these: the production of SAM from methionine, the serotonin, melatonin, and niacin from tryptophan, catecholamine, thyroxine hormones, and melanin from tyrosine. Decarboxylation requires vitamin B6. Vitamin B6 is required for transamination, deamination, and decarboxylation. All these three processes require the vitamin B6 in the form of pyridoxal phosphate. Okay. All right, so that was about the special products, and also make note of the catecholamine synthesis. Lots of coenzymes are required in catecholamine synthesis. Conversion of tyrosine to dopa requires tetrahydrobiopterin. Conversion of dopa to dopamine requires pyridoxal phosphate because it is again a decarboxylation. From dopamine to norepinephrine, we require the copper and vitamin C, and conversion of norepinephrine to epinephrine requires SAM. It requires SAM. Okay. Creatinine is a waste product. Creatinine is a waste product. Production of creatine requires the arginine, glycine, and the methionine. All right. Okay. One important concept: post-transcriptional modification of hnRNA into the messenger RNA, hnRNA to messenger RNA. It requires the 7-methylguanosine at 5' end. It requires the poly A at the 3' end, and splicing. These are the three changes which are included in the post-transcriptional modification. Okay, post-transcriptional modification require the addition of 7-methylguanosine at 5' end, poly A at 3' end, and splicing. Okay, diagnostic tool for the neonatal screening program. Nowadays, a lot of states are rolling out the neonatal screening program. It has been working for a long time in the Western world, but now in our country also some states are rolling out the neonatal screening program. So there, the preferred test will be the tandem mass spectrometry. In the question, it will be written as tandem MS. Tandem MS is tandem mass spectrometry, and here what you have to remember, we are using two mass spectrometer linked in series. That's it. Two mass spectrometer linked in series. First one will carry out separation. Second one will identify each of the separated molecules. Second one will identify each of the separated molecules. Okay. Now, heme catabolism, repeatedly the question is coming. You have to remember three products coming out from the heme catalysm. First is ferric iron. When you synthesize, you use ferrous iron, but when there is breakdown, at that time you are getting the ferric iron. We'll come to epigenetics. Don't worry, we'll come to epigenetics. Don't worry. TMS, tandem mass spectrometry, is correct. Second, biliverdin. One heme will give you one biliverdin, and most importantly, carbon monoxide. Only reaction where physiologically carbon monoxide is produced. So you remember these three things on the breakdown of heme. We get biliverdin, we get the ferric iron, and we get the carbon monoxide. Okay, COF3 and biliverdin. These are the three things you get. Not ferrous iron, not carbon dioxide. Okay, please don't make that mistake. These three are very, very important. Again, we are getting question about the insulin dependent and insulin independent uptake. What you have to remember, that GLUT4 is the one which will be affected by the insulin. GLUT4 is present in the muscles, whether it is cardiac muscle or skeletal muscle, and the adipose tissue. Second point, you also have to remember, when there is fasting, overnight fasting, these receptors will go inside. So what will happen? There will be decreased concentration on surface. So this is second type of question which is asked. You have to remember, after overnight fasting, decreased concentration of the receptors occurs on these three tissues: cardiac muscle, skeletal muscle, and adipocyte. So number one, these receptors are affected by insulin, and number two, after overnight fasting, these receptors will go inside. These receptors will go inside, and therefore the concentration will be decreased after overnight fasting. Second, the RBC contains only GLUT1. All tissues will have GLUT1 plus something else. All tissues will have GLUT1 plus something else. RBC has only GLUT1. This is second important question that you have to keep in mind. Others, I'll not go there. No point in going to the others. Now, coming to the Chargaff rule, Chargaff rule is for double stranded DNA. That means adenine will be equal to thymine, guanine is equal to cytosine, and purine is equal to pyrimidine. If your genetic material is RNA in nature, then the Chargaff rule does not apply. Please remember, Chargaff rule will apply for double-stranded molecule. If your genetic material is single-stranded RNA, then the Chargaff rule does not apply. According to Chargaff rule, in double-stranded DNA, adenine will be equal to thymine, guanine will be equal to the cytosine. Okay, okay. Then glycogen phosphorylase is another very important repeated question. So here you have to remember two things. It is activated by calcium and AMP. It is inhibited by free glucose in liver, and it is inhibited by ATP and glucose 6-phosphate in both liver and muscle. Okay, in both liver and muscle, ATP and glucose 6-phosphate. Only in liver, free glucose. Free glucose will not act in the muscle. Activation by calcium and AMP. About calcium, you have to remember it activates directly, and it also activates via calmodulin, means it is acting indirectly as well. It is acting indirectly as well. Moving on to RBC. RBC uses only glucose. Only glucose. RBC uses only glucose. It cannot use the ketone bodies. It cannot use the fatty acid. So fed state, fasting state, starvation state, early starvation, post starvation, whatever is there, only RBC. Only RBC. ठीक है, चलिए. RNA I and microRNA, same question. Okay, RNA I stands for RNA interference. It acts through knockdown. Knockdown will have three mechanisms: mRNA degradation, mRNA destabilization, and prevention of translation of messenger RNA. These are the three methods by which RNA interference, that is knockdown phenomena, will work. And this microRNA acts by interacting with messenger RNA at the 3' untranslated region. Okay, microRNA will act on messenger RNA by interacting with the 3' untranslated region. It matches the sequence. If the match is there, then RNA interference will happen. If there is no match, both of them will go their own way. Okay, and the role of microRNA is for regulation of the gene expression. Knockdown, knockup is happening at the level of DNA, not at the RNA. Knockup. There is no knockup. There is knock-in and knockout. I'm so sorry. Well, there is knockdown, which is mRNA. There is knock-in and knockout. Knock-in and knockout will happen at the level of DNA. Knock-in means you add something. Knockout means you take out something. Knock-in, there will be gain of function. Knockout, there will be loss of function. Knock-in is generally frowned upon. Knockout is the one which we are doing routinely for the research purpose. Knockout means you take out a gene and there is loss of gene function. Okay. Okay, I'll just write quickly. Knock in means you add gene. Knock out means you delete the gene. When you do knock in, there is gain of function. When you do knockout, there is loss of function. Alright. So that's it. Don't have to remember anything beyond this. Both of them, knock in and knockout, are happening at the level of DNA. Both of them happening at the level of DNA. Little bit about nutrition. Which of the following consumes highest energy during assimilation? What they are basically asking is the thermic effect of food, also known as the specific dynamic action of the food. How much energy we spend for metabolism? How much energy we spend for metabolism? Another 5 minutes. That's all. Just another 5 minutes. Okay. So the carbohydrate thermic effect of food is 5%. Very easy to digest. Lipids, slightly more energy is required, 10 to 15%. And most difficult to digest are the amino acids and proteins. Up to 30% of the energy content is utilized for metabolism itself. Okay, no, we are not going to CRISPR-Cas. That is old story. Don't go there. We'll focus somewhere else. Don't worry. Okay, then which of the following is amphipathic triacylglycerol and cholesterol ester? Okay, and very commonly asked question, wobble hypothesis. Wobble hypothesis is explaining the degeneracy, and both of them together are responsible for silent mutation. Both of them are responsible for silent mutation. Last part which you're asking about the epigenetics, the effect of DNA methylation. In DNA, we have only one change, that is methylation. It is going to cause the decrease in gene expression. It is going to cause decrease in gene expression. And effect of histone acetylation. In histones, we have a lot of changes, but most important is the acetylation, which is going to cause increase in gene expression. Two more points about DNA methylation. DNA methylation commonly occurs in the CPG islands. It will commonly occur in the CPG islands. CPG islands are part of the enhancer element. CPG island are part of enhancer element. CPG island are part of enhancer element. Okay. Before I close, just 2 points about PCR. PCR is used for identification, and where you need the 6 important substrates. First, template DNA. What you have to remember, this is the only variable element. This is what comes from the patient. The template DNA is what comes from the patient. The rest of it we give in the lab. What do we give in the lab? We give the tag polymerase. Along with this, we give the building blocks, that is DNTP. We give the primers. We give the activator for polymerase, that is magnesium, and we give the buffer to maintain the pH. All this we give from the lab. The variable component is the DNA which is coming from the patient. Second, we have something called multiplex PCR. See, this is again going to land up in the exam. 2 years back it was there. It is for syndromic diagnosis of meningitis. We had used this during the pandemic. We have used this during the pandemic, but now we are using it for the syndromic diagnosis of meningitis. In the same tube, you can identify 3-4 infections for meningitis. You can test for each of them. Whichever is positive, you will know your diagnosis at one shot. And one shot, you can identify the cause for meningitis. Okay, DNTP means deoxyribonucleotide triphosphate. There will be building block for the DNA. In PCR, you are amplifying the DNA, right? So you need the building block for the DNA. You need the building block for the DNA. When you're doing the histone acetylation, that is activation. When you do the histone deacetylation, that is inactivation. Okay, when you give the histone deacetylation, that is inactivation. You don't give anything to stop the PCR. You just stop the machine. Okay, you just stop the machine. You just need to stop the reaction when you're doing the RNA amplification. For DNA amplification, we don't need to give anything to stop the reaction because it happens at a specific temperature which is optimum for the enzyme. You remove the temperature, optimum temperature, the reaction will stop. You don't need to give anything to stop the PCR. You just decrease the temperature, you bring the temperature back to normal. Okay, I think these are some of the most important topics which I wanted to discuss. One, odors is there. Please take a look at odors. Mousy or musty odor for PKU, burnt sugar odor for maple syrup urine disease, fruity odor for ketoacidosis, I told you, boiled cabbage odor for tyrosinemia, swimming pool odor for Hawkins synuria, also known as chlorine-like odor. Simulation is a type. Simulation is a type of the histone modification, but you can ignore that. You can ignore that. It is a type of the histone modification. Okay. Just one more minute. I'm so sorry. Zellweger syndrome. Peroxisome is absent or defective. Okay, absent or defective. Liver cannot use ketone bodies because enzyme thiophorase is absent. Thiophorase is also known as succinyl coenzyme acetoacetate coenzyme A transferase. And in Zellweger, okay, what you written is correct. In Zellweger's, VLCFA will accumulate in CNS, liver, kidney. And last, that lipid up to 30% in diet is normal. Last point. That is the last point. That is the last point for my side. The 30% of lipid in the diet is normal. So until you have 35% or more, we'll not call it the fatty I have taken a lot more time than I was allotted. I'm very, very sorry, but I could not stop in highlighting the very, very important topics for you. I hope you are able to score well with this quick revision of biochemistry, and I've tried to cover what I felt was must-know topics for you. And I'm very, very hopeful that all the questions, the 14, 15 questions that we are getting from biochemistry will be from what we have done today. In ref sums, you will only have peripheral neuropathy. Only one enzyme is defective, which is causing the breakdown of the branched fatty acid, the phytanic acid accumulation. So in ref sums, the question will mention the question will mention phytanic acid. When you see phytanic acid, then we are dealing with ref sums. There is deficiency of one enzyme, the dioxygenase, phytanyl coenzyme dioxygenase. That is the only thing which is deficient. So there is peripheral neuropathy, the depulsion of the phytanic acid. Okay, so that is all from my side. Thank you very much, and take care, and best of luck for your exam. I'll be signing out here, and take care, and bye bye.